Macular degeneration is a leading cause of vision loss, with 15% of Americans being at risk or already affected. Scientific evidence proves that by using mesozeaxanthin, lutein, and zeaxanthin together replenishes the macular pigment and promotes healthier vision. This formula comes in only one product, MacuHealth.
Hi, this is Dr. Kerry Gill, the host of Open Your Eyes. And today I have a very, very special guest, Dr. Michael Tolentino. Dr. Tolentino is a very, very famous retina specialist, not only here in the US, but worldwide. He did his ophthalmology residency at Harvard Medical School, Mass Eye and Ear. He did his retinal fellowship at UPenn Shaley Eye Institute. Dr. Tolentino has developed many techniques, medicines that save people's eyes and even life over years, because he's done some work with cancer. He has many medical patents. He's the founder and director of the clinical research program at the Center for Retina and Macular Disease. He's published over 100 publications. He's an associate professor of ophthalmology at the University of Florida. He's the best lecturer that I've ever heard. When Mike is speaking, it's like watching a movie that you don't want to end. So Mike, I really appreciate you coming on. The retina is really the most amazing part of the body. We can learn so much from the retina. So give us a little bit of background about your history, why you became a retina specialist. You tell that great story about your dad.
Well, my dad is one of the pioneers in the field of retina. He actually wrote the first book on vitreoretinal surgery, and his group at Harvard Medical School, the Statins Eye Research Institute, is the premier research institute for retina and eyes in general. He was working there before I was born, and when I was born, we're an Asian family, so as a result, you know, if in an Asian family, if your parents run a Chinese restaurant, well, you have to work in the Chinese restaurant. Well, my dad was an inventor and a surgeon, and so and he was a professor at Harvard Medical School. So, like any good Asian family, instead of me playing with my friends, I ended up having to work in his laboratory and helping him with his books and also developing surgical techniques for retinal disease. And also I had to learn how to use the examination tools that we use to examine the retina, which is what was developed by to the back of the eye, and his group, Dr. Charles Skeffing's group, actually was the one that developed that and invented it.
So explain to
there's actually a model of that machine. I'm sorry? There's actually a model of that machine at the Smithsonian Institute. So
we were having a little technical difficulties there for a second.
Oh, is it okay?
Yeah, now we're back.
Okay.
Okay. Yeah, for some reason it froze. So explain what the retina is and what a retina specialist is.
Well, the retina is what allows us to see. It actually translates the light signal into a brain signal that we can interpret, which is very important. Think of it like the digital chip inside one of your digital cameras, like your iPhone, etc. It allows the light to be translated into an image that can be translated by your brain. And that's why it's very, very important. The other issue is that really the retina is the brain. It's an extension of the brain, or it is part of the brain. And as a result, it is why we can actually see. It was the development of this retina that really allowed us as the human race to be able to visualize things, and allows animals to see things and have that true sense of vision.
The retina is full of blood vessels, and
yes,
it's the only place in the body that we could see the blood vessels. Explain how the retina is such a good biomarker to systemic health.
Well, the retina is the brain, as I said, And as a result, the blood vessels in the retina are representative of the neural blood vessels or the brain blood vessels. Now, this allows us to really have a window into the brain without having to use an MRI, CAT scan, or any other X-ray device. It is the best way we can visualize the brain without having to do anything super invasive like cutting a hole in your head, all right? So that's why it is so, so valuable in evaluating systemic conditions that can affect the brain. That can include Alzheimer's, that can include diabetes, that can include hypertension, it can include cancer, okay? It can include anemia, because you're actually looking at the brain's blood vessels through the retina. And that's why it is such an important tool for physicians around the world in all specialties.
So if we use the retina as a biomarker, say for Alzheimer's, what are some of the things that we could see in the person's retina that may give us a clue that they may be getting a neurodegenerative disease, such as maybe Alzheimer's or Parkinson's?
When I was at the University of Pennsylvania, we identified a link between Alzheimer's and macular degeneration. Macular degeneration and Alzheimer's are really literally the same complex of things. We can actually do testing. We can look at the back of the eye, identify a certain type of deposit that's found in the retina that would predispose a patient who has these deposits to developing Alzheimer's disease. The other thing that we can use as a biomarker is we can actually do a test where we stain the retina with a certain stain, and it can show up these things called amyloid. Amyloid is these plaques that occur at Alzheimer's and are the precursor to the loss of memory that you get with Alzheimer's. The other issue is that you can look at the blood vessels and identify if a patient has high blood pressure or diabetes. Of course, you can identify eye diseases like macular degeneration as well. But this is invaluable. If you can see the retina, it's invaluable for a physician to give a prognostication for patients and also to give diagnoses to patients.
What will the doctors see if somebody has high blood pressure? What will the blood vessels look like? And if somebody's at risk for a heart attack, what would the blood vessels look like in the eye?
Okay, so let's start out with high blood pressure. High blood pressure, think of it like putting a garden hose onto a fire hydrant. What's going to happen to that hose? It's going to get all squirmy and it's going to start leaking. Okay, it'll burst small little leaks in the hose, and then the hose looks very, very squirmy. A patient who has high blood pressure or uncontrolled blood pressure will have a lot of squiggly blood vessels in the back of their eye. And also they will have these areas of what I call popped blood vessels. They're called cotton wool spots. And cotton wool spots are little, they look like cotton, you know, on the retina. If a patient has that, their blood pressure ain't controlled. And I can tell them, even a lot of my patients, they go, oh yeah, I take my blood pressure medicine and I don't eat salt and all that kind of stuff. And I look at them and I go, well, you're not doing a good enough job. you better do that better. And then they always come up with the statement, oh, I measure my blood pressure like when I go to the doctor and it's fine. Well, you measure the blood pressure at your doctor's office maybe once a year or twice a year. Of course it's gonna be fine. What about the rest of the year, okay? And I can actually tell a patient, you know, you're not really well controlled. I don't care what your doctor says or what you measured in the doctor's office. Now, when it comes to other diseases like diabetes, for example, diabetes also can demonstrate certain things in the back of the eye. A lot of little bleeders, that's what occurs. It also can have these things called, they're like fatty deposits that show up in the retina. We call that exudate. Now, you asked about how can we identify if somebody is going to have a heart attack or have a stroke. Well, a lot of times we can see cholesterol on the blood vessels in the retina. And this is like looking at your heart arteries and seeing these fatty deposits that are going to cause you to have a heart attack. So we can diagnose a hell of a lot of things just by looking at the retina. that will help keep you healthy and preserve your vision, as well as help the doctor manage your problems, in particular blood pressure, cholesterol, and also diabetes.
Now, the blood vessels in the eye, are they different than the blood vessels in the brain, or the blood vessels in the heart, the blood vessels in your feet?
The blood vessels in the eye are different and yet the same. Okay, they behave differently, and I'm a vascular biologist. I trained at one of the best laboratories at Harvard Medical School, a gentleman named Dr. Judah Folkman. And Dr. Judah Folkman was the world expert on the different blood vessels and blood vessels in different parts of the body. While there are similarities between blood vessels in the brain and the eye, they behave differently. And that's why it's hard to generalize the blood vessels. There's a problem with the blood vessels in your foot if you're going to have a problem with your eye. But the eye is the most sensitive blood vessel to damage. As a result, it's like one of the earliest indicators for disease. You'll get problems in your eye before you get problems in your feet, your heart, and your brain. So that's while the blood vessels are different, they are the same in many ways. Okay, and we have to utilize the eye's blood vessel differences to predict problems with other parts of your body.
So typically you see patients when the wheels are coming off the bus, pretty much. What are the most common diseases that you typically see of the eye and that you could actually help these people from going blind?
The most important actually likely is diabetes. The epidemic of diabetes our diets, our way of our everything that we are doing in our society, we're much more sedentary, is creating a tsunami epidemic of diabetes. And this is to me, having grown up in the field, that the incidence of diabetes is extraordinary. Plus, the effects on the eye are also quite extraordinary. And it's very disconcerting. I mean, it truly is an epidemic, and probably one of the most important things and most common things that I see. Of course, the second one is high blood pressure. A lot of people, we have so much salt in our diet, and we do not exercise adequately. And as a result, our blood pressures go off kilter and cause us to have strokes and also eye problems. That also incidence has been rising tremendously, again, based on the culture and our diet. And then, of course, the third is something called macular degeneration, which because of the proliferation of computer screens and indoor light that really mimics the daylight or the sunlight outside, it's increasing the rate of development of macular degeneration, which will be devastating for future generations. But those are the three most common things that I look at in the back of the eye.
So let's talk about diabetes for a second. So what are some of the signs and some of the symptoms the patients have when they come to see you, and what can we do to help those patients?
Actually, the most common sign for a diabetic is their glasses don't work for them, or they feel like they need glasses, or their vision is blurred. That actually is the most common presenting sign of a diabetic. Once a patient comes in, and a lot of times the patients don't come to see me at that stage. They see our colleagues, okay, my general optometric colleagues. And of course, they're given glasses, and of course, for a short period of time, it works. But that the bottom line is that that's really the first sign that diabetes is happening and diabetes is uncontrolled. The second most common sign actually is the formation of early cataracts. Early cataracts, there's a certain type of cataract which is an opacity on the lens inside your eye. It's like a little cloudiness, right? And that occurs at a younger age in diabetics. And sometimes the only reason they would have cataracts is because they're diabetic. But because it doesn't really affect them, or they haven't had any other symptoms, they don't consider themselves diabetic. As a result, they don't go to see the doctor to get checked. The third, of course, which is less common but more important, is that you start seeing bleeds inside the retina. If the retina starts bleeding, there's only a few things that can cause that, and that diabetes number 1, diabetes number 2, and then other conditions. So that's exactly, why it's so important that if a person comes in, or if you start developing blurred vision, don't just say it's something else, it's your glasses or whatever. It could be a sign that you're diabetic.
So you said we lost a little bit with the technical difficulty. There were three, if it's bleeding in their eye, there are three main things that you see. Can you repeat that?
Okay, the three main things. The first one is, of course, blurred vision. Okay. Second is cataracts, a certain type of cataract. And the third is bleeding in the retina. Small bleeds we call dot blot bleeds.
The things you said, the most common causes of the bleeds.
Well, I lost you there for a second. Can you repeat that?
What are the most common bleeds in the retina? You said before.
The most common bleeds in the retina are very small bleeds that don't affect your vision at all.
But what diseases are they from?
The most common is diabetes. The second is diabetes. The third is diabetes, and then there's high blood pressure.
we lost you on that. That's why I had to repeat that. I'm sorry.
Yeah, sorry. Thank you. Yeah. But yeah, if you have a bleed in your eye, I would guess you're diabetic. The issue is that when I find bleeds in patients' eyes, they automatically always say, no, I'm not diabetic. I'm going, well, you're not diagnosed with diabetes, but you likely are diabetic. Sorry, what can I say, right? I'm just the messenger. I'm not the creator of your problem. All right.
So what causes the person's vision to get blurry when they start bleeding in the eye where they can't see?
Well, the vision gets blurred. Well,
if it's from the retina.
The problem is that I'm considered a world expert in the pathogenesis of that. I'm going to try to make it understandable to the common person. All right.
Good.
I'll have to use some big words. I apologize, but that's the only way I can explain it. Let's start out with what diabetes does to the eye and the body. The only thing diabetes does is it fills your blood levels up with sugar. All right. Now, sugar isn't bad. I mean, we eat sugar. We have a good time with it. I just ate ice cream. It's great, right? I don't drink sodas too much, but too much sugar. What happens is that it sits in your bloodstream, and what it does is it coats the cells inside your body and in your blood vessels. All right. Unfortunately, think of it like caramel. I'm sure you've eaten caramel on top of your ice cream sundae, right? Imagine caramel coating the inside lining of your arteries and your blood vessels, okay? That's not a really pretty picture, correct?
No.
That's exactly what you're doing when you're diabetic and you don't take care of the diabetes and your sugar is so high. So what happens is that the sticky sugar, that's the caramel that's lining your blood vessels, it causes a lot of problems. And the problems that it causes is it makes the blood vessels or the cells in the body produce these fertilizer growth factors, we're called. Growth factors are what allow us to grow things like blood vessels, and to our skin, there's a skin growth factor. Our hair has a growth factor, that's why it grows. Also fat, there's growth factors for fat, that's why we get fat, all that kind of stuff, right? And so the sugar stimulates these growth factors that produce something called blood vessels to grow. And that's a big problem. It also causes it like attracts these things called inflammatory cells that block up blood vessels. So as a result, you have these blood vessels filled with inflammatory cells, and then also these growth factors being produced because there's so much sugar caramel coating the blood vessels in the cells. As a result, you start blocking off small blood vessels in the retina. And if you block a small blood vessel in the retina, it's going to have a backup and pop. And that's where you get these bleeds from diabetes. It gets even worse than that, because what happens is that these blocked small blood vessels from the caramel and the cells, they will cause the blood vessels that are already there to leak. And this is where we have the most visual loss from diabetics, because the blood vessels that are already there, they're not new blood vessels. The old blood vessels that are there that are being blocked up, they start leaking fluid. And then you form a blister inside the center of your vision, and you don't see very well. And that really is the main visual loss. And it's not the small bleeds, it's the leak that the small bleeds cause. And that's really the pathogenesis of the blinding situation for diabetic patients. Make sense?
Yes, so that was a beautiful explanation. Explain when you decide that it's time for treatment and what the different treatments are. If there is swelling of the center of the eye, the macula, we have macular edema, that's called, what you just beautifully described. When do we have to treat it? As soon as a little bit of swelling, or do we need a lot of swelling, or do we have to wait for the vision to go down? When do you make the decision as a retina specialist that you have to treat that person?
A lot has changed in the last 25 years, all right? In the past, we would not treat this until we saw that there was going to be some visual loss, all right? You'd have to actually form the swelling before we could treat it, and we would treat it with various techniques, mostly laser, sometimes surgery, all right? And sometimes we would give an injection of a steroid. But in 1993, I invented a class of drug, of course, with a team at Harvard Medical School, where we actually treat the underlying cause of the bleeding and the leaking. It's this growth factor I was telling you about. And we developed an injection that we give into the eye that can actually block this growth factor that's produced by the caramel-coated cells inside our eye, right? We've developed it over the last almost 25 years, and now it's become the staple of therapy for retinal disease. Now, we just finished a trial where we were injecting the eyes of patients who just had small bleeds, but their vision was not affected. And we discovered that this was able to stop patients from losing vision. And it was FDA approved for that. Now, the injections are now used in patients who have any sign of bleeding in their eye from diabetic retinopathy, and that's indicated. Now, I have a philosophical problem with that, because the best way to really treat this early disease is not to give shots, but to actually manage your diet and also manage your weight and also exercise. If you catch a patient with this early sign of bleeding, it'll take them probably several years to develop visual loss. In those several years, you could actually reverse the diabetes by eating right, watching your carbohydrate intake, exercising appropriately, and trying to lead a fairly good life. That's what we should be advising patients who are diabetic, not telling them that they need shots. So philosophically, while we do have the standard of care amongst my colleagues is to give shots to people with bleeds, early bleeds in diabetics, I don't think that should be the appropriate standard of care. The appropriate standard of care should be to manage the diabetes better so that they won't get into trouble, all right?
when it comes to heart, people that have heart attacks, sometimes they grow new blood vessels and they get these collaterals. There's
Yes.
actually a technique that you could do, this EECP technique, enhanced external counterpulsation, where they actually put like blood pressure cuffs on your legs to get you to grow collaterals in the heart.
Yes.
So if we prevent collaterals, how do we know when the collaterals are good and when the collaterals are bad? So do we have to worry, like, if we're injecting with anti-VEGF, that we may prevent the collaterals, good collaterals, helping people with their heart?
Absolutely. Back in the day, remember, I helped develop both the anti-VEGF and also the pro-VEGF therapies. When I was at the University of Pennsylvania at the Kirby Center for Molecular Ophthalmology, I developed something called gene therapy, all right? I was working with the cardiology department to actually put a gene therapy vector into the heart to increase the levels of this factor called VEGF in the heart so that collaterals could form. Now, what's very interesting is that that is a very successful concept, but the heart is a difficult organ to study, especially in patients who have heart attacks. And most heart attack patients it's hard to give an injection into the heart. I'm just saying, it's actually easier to do that in the eye. So that research hasn't really gone so far because of the problems of injecting the heart at the time when somebody has a heart attack, right? Now, the problem is that having helped invent the anti-VEGF drugs, I know that there is a risk that if you had a heart attack and you give the shot, you could actually cause another heart attack to occur because you block off these collateral blood vessels that are supposed to grow back and refeed the heart for blood once a heart attack has occurred. Again, it's why I don't suggest in patients who have early diabetes that they should try to take care of their sugars first before they get these injections. Diabetics have a propensity, an increased risk of heart attacks. And usually they're silent heart attacks, and they're small heart attacks until eventually the heart doesn't work too well, and then you go into heart failure, and then you don't do so well. This is a very common story for diabetics. I mean, my mom, who is bedridden right now, she's diabetic, and she is dwindling away because of heart failure. She's had multiple small heart attacks that were never the big one. Oh my God, I have big chest pain. No. These are all small, undetected until you go to the doctor's office, you do an EKG, and you go, oh my God, there are 3 vessels here that are completely blocked. They're small blood vessels, but her heart doesn't work. Her heart now works at 15%. And that's why she's in oxygen. She has to stay in bed. She can't walk, and we have 24-hour health care for her because she can't even walk to go to the bathroom, all right? Now, this is what happens to a lot of diabetics. Imagine if we keep on injecting somebody's eyes over and over again, stopping the heart from reperfusing these small heart attacks. You're gonna end up like my mom much sooner than you would. So that's why you have to be responsible when we start giving these shots. There are side effects of anything that we do to treat something. Okay, the best treatment is to have a conservative treatment. Like I said, eating correctly, exercising ain't gonna kill you. All right, these injections will. So I know I keep on stressing this, but I have a lot of patients who are diabetic. They come to me and says, oh, you can fix me anyways, right? So I can just eat whatever I want. I can do whatever I want. That's not the message I want to portray here, all right? It's really the bottom line, okay?
Talk about some of the really interesting instruments that you have in your office to help with early diagnosis.
Well, we have of instruments. Patient has really changed the way we do medicine. Just the cameras alone that we have are phenomenal. There is a groundbreaking machine called the optical coherence tomography machine called OCT. And the OCT actually slices and dices the retina, and without having to slice and dice it. But we can see it just like a CAT scan or an MRI, and we can look at the whole retina overall and look at any subtle changes in the retina. We also have a camera that can look at or take a picture of the whole retina. It's called an Optos camera. The Optos camera is a wide field camera that allows us to see all of the retina, just a small portion of it, or just the macula. Then other technologies include something called, I have this machine actually in my room here. It's called a Maya microperimeter. And we're using that a great deal because when you have small bleeds in the retina, you're going to cause small blind spots. And typical measurements of your vision on an eye chart are not going to be able to detect any blind spots, except if you use something like this microperimeter Maya. I also have something called dark adaptation, which what happens when your retina is all sludged up, remember I told you with all that sugar, it actually causes our eyes not to be able to adapt to darkness. And this is a machine that measures that, and it will pick up really a damaged retina or ischemic retina, which is, I mean, again, phenomenal. This is all early detection of diabetes or diabetic eye disease or loss of vision from diabetes that we couldn't do before. Now, granted, we now have a therapy that we can introduce early on, which is this, which is really this injection. But what would be more important actually is to manage the sugars better. And the technology for managing sugars are fantastic. There's these machines called continuous glucose monitors that I prescribe to all my patients if their insurance covers it. And that allows them to actually look at the consequence of what they do. I'll give you an example. I have a patient who thought that, that eating carrots was good for him, but he's diabetic. And so I had him get this continuous glucose monitor, and then he ate the carrots and his sugars skyrocketed. And he goes, oh my God. So he stopped eating too many carrots. He didn't take it completely gone, but he stopped eating too many carrots because carrots have a high glycemic index. I mean, same thing with oranges. I live in Florida, so they drink a lot of orange juice here, right? So I have some diabetics who come in and go, oh, orange juice, fantastic, orange juice, it's healthy, right? And then they do this continuous glucose monitor. They drink 1 cup of orange and their sugars go up to 400. I mean, it's like, that's the best way to monitor and teach the patient exactly, what's good for them, what's bad for them. The other thing is that I have some patients who exercise a lot, way too much, especially if they're diabetic. They think that's really good for them. But what happens is that like they're on the treadmill for an hour, right? And their sugars go down to like 60. That ain't good either. You're gonna pass out, right? So if you're gonna do the treadmill, you got to have some sugar, right? And this is, I think, more important than me giving a shot to somebody's eye once a month for the rest of their lives, right? I mean, I think you agree with me, Keller.
Oh, absolutely. Fantastic advice. Let's switch over to macular degeneration. You're
Sure.
one of the world experts in macular degeneration. You're the inventor, developer of therapies to treat macular degeneration. Tell us what macular degeneration is.
Degeneration is really a rusting away of your vision. That's pretty much what it is, okay? It corrodes, and also it's the killing of the retina cells as they get older. And if you understand that, you understand macular degeneration. What you have to do, though, is understand why do we rust? That's number one. And also, why do the cells in the retina die? That's number two, okay? And science has really come up with a lot of the answers just in the last 4 to 5 years. So the question is, why do we rust? And why do we rust mostly in the center of the vision, which is called the macula? That's why it's called macular degeneration. We don't talk about peripheral degeneration, which is the retina outside the center, only the center. The main reason is because that area of tissue receives more light than any other part of the body. And the light that you receive actually is very, very focused and powerful. We have a lens system, like our eye is like a camera, and our lens is very, very powerful. It's one of those super zoom lenses, correct? And what that does is it actually amplifies or intensifies the light, and it puts it into a nice point right to the center of our vision. So imagine when we wear glasses, right? We wear glasses to focus the image so that it lands right on the center. But what that does is it behaves like a magnifying glass when you're trying to start a fire on a leaf. It intensifies the light. So light that is not normally harmful or burning becomes something that can actually, your center of your vision is very exposed. It's like the pinpoint of the magnifying glass where you start the fire on the leaf, all right? Now, what light is bad? Well, almost anything that's like in the what we call ionizing range, which is blue light, violet light, ultraviolet light, gamma radiation is always bad for the eye, okay? Now, the problem is that UV light doesn't get to the back of the eye. So the only ionizing radiation that can get to the back of the eye is between 500 and 400 nanometers. Now, what is so special about this ionizing radiation? Ionizing radiation is just defined as something that can cause something called oxidation. Now, most people don't understand what oxidation is, but oxidation is just rusting, okay? So the only form of photorusting that can occur is with this particular wavelength of light. As a result, that's what initiates and propagates the macular degeneration, which I told you is just rusting, correct? Now, the other factor that just was recently discovered is, why did the cells die? Well, they die because there is a genetic switch that is found in our retinal cells, that if you expose to this blue light, which is photooxidative, right, it will cause the retinal cells to commit harikiri. Harikiri is a form of death or suicide that is very well described in the Japanese literature. It's a very clean, programmed cell death, all right? And all you have to do to kill these cells and cause the blindness from macular degeneration is to shine this wavelength of light, which is 445 nanometer, which is right in the blue spectrum of light, on the retina, and it will cause the cell to signal cell death. And it's a really clean death. It's not like, you know, bloody and all that kind of stuff. It's just the cells just die, and then they get cleaned up, and then you have a blind spot in the back of your eye. I just described something called dry macular degeneration, all right? There's another form of macular degeneration called wet macular degeneration. And again, it's caused exactly by this thing called oxidation or rusting. Think of your car, and you spray it with salt water every morning, okay? It's like looking at, I'm unprotected on the screen because the reflection off my glasses, I'm not wearing my glasses. So I would never usually do this. I would always wear my protective glasses before I look at the screen this long. But you know, for video purposes, I'm okay, right? But I've already been in front of this computer for 45 minutes or 30 minutes or so. And I know that several of my cells in my retina are killing themselves, okay? I know that. But thank God I have close to 1 million retinal cells. So if I lose 1 or 2 now, that's okay. Imagine when I get up to 85, right? And I've done this a lot. Well, my 1 million retinal cells, a lot of them would have killed themselves already. Now, the other thing is that when this programmed cell death occurs, it stimulates something called inflammation. It's a form of inflammation that is very subtle. It's not like when you get a virus or a flu and you know, it's really, really bad. It's a subtle inflammation. And that's what the inflammation was designed to clean up the dead cells. Think of them like you know, when there's a big war and there are a lot of dead bodies, correct? And you have these people who go in and collect the bodies and then they dispose of them, correct? Well, those are inflammatory cells. The problem is that these inflammatory cells, they can get pissed off and they start producing this factor called VEGF, which is what happens when you coat blood vessels and cells with sugar, right? And as a result, you have the possibility of developing new blood vessels that grow into the same area where the cells are dying. Not a good situation, but we have a good treatment for it, those injections again that we were talking about. So in this short 5 minutes, I've explained to you the whole pathogenesis of macular degeneration. And it also gives you clues in terms of what you can do as a patient or somebody who may develop macular degeneration in their future, how they can prevent that. Very similar to diabetes, we have now preventative strategies that can help us slow down the disease.
Vision Edge gives you less eye strain and reduced damage caused by blue light. We like to call Vision Edge sunscreen for the eye. It all starts with your highest level of visual performance, only achievable through scientifically proven Vision Edge.
Thank you for tuning in to the Open Your Eyes podcast. If you like the video you're watching, please hit the like button. Also, hit subscribe for weekly new episodes of the podcast, along with pod winks and bonus content. All right, let's get back to the show.
Now, the blue light coming off the computer is unopposed there's no infrared to kind of balance it or UV to balance it. It's just blue light, and people are looking at the computers all day. How dangerous, if we could just talk about how dangerous that blue light coming off the computer, is it dangerous or is it not dangerous? What do you think?
Well, I would say 15 years ago, it wasn't dangerous, all right? It's because the amount of light that was coming off the screens, the bad light, and again, the bad wavelength of light is called 445 nanometer blue light, all right? It was approximately 1/10 the strength of a sunset, all right? Now, I have an iPhone 7 here, all right? iPhone 7 is actually, at this setting, which is a medium brightness, is about 2 times the power of blue light that comes out of a sunset. In my backpack, I have an iPhone 11, which I don't like to use too much because it actually is close to 7 times that of a sunset. All right.
Wow.
So, back in the day, I'll give you an example. I just saw a patient maybe 3 weeks ago. He's 22 years old. All right, he was in college here, in local college over here, and he was given an iPhone 11, probably for Christmas. Before that, he was with an iPhone 7. Now, college students, they live on this thing, right? Well, what happened is that he started using the iPhone 11 the same amount as he was using the iPhone 7, and he lost vision.
Wow.
Yeah, he noticed it, and that's why he came here. And he went to one of my colleagues who couldn't find anything wrong, okay? But what I found, actually, when I looked into his eye, now, of course, I'm an expert, et cetera, he was starting to develop drusen, which is the hallmark sign of macular degeneration. But he's 22 years old.
Wow.
That sucks. I mean, I have so many cases of that, and people don't realize this. It's because this is the first generation that has been able to expose themselves to sort of really high-powered light, okay, visible light in the blue spectrum. Again, I always harp on 445 nanometer because 445 nanometer is what comes out at peaks from computer screens, from iPhones, from sunlight, daylight, etc. And that's the one that triggers the cell death in the retina. And that's why this patient, 22-year-old, he lost vision. Hopefully, I don't know if he'll get some of his back, but functionally, he's lost vision. All right.
Wow, that's incredible.
Well, it's sad. All I'm saying is it's sad. What are we doing to ourselves?
And the generation that's growing up now. So what kind of filtering glasses should people wear to protect themselves against blue light?
Well, it has to be ones that filter 445 nanometer blue light. Now, I've tested 53 different lens types. The only one that I found was a Canadian brand, okay? It's called True Blue Lenses, and it uses something called pigment impregnated technology. Now, there are other glasses that use that effectively. I'll show you my glasses. They're kind of yellow. That's why they reflect, okay? And the problem with this is that they're sort of yellow, so people look at it and say, oh, it looks urine colored. So initially, when I was trying to convince my 21-year-old son to wear it, he goes, Dad, I don't look good with this. I said, son, if you want to use that computer that I just bought you for school, you better wear this, otherwise I'm taking that away. I'm also going to take away your iPhone, okay?
Right.
And so he uses that, and you know what he finds? He was having sleep disorder, right? College students they party too much. You know how that works, right? And they don't get enough sleep, right?
Yes.
Well, after he started wearing these glasses, and then he now wears sunglasses to use his computer. He has a 5K Macintosh. 5K Macintoshes are like super powerful. This Macintosh I'm using right now, it's a weaker one. I haven't upgraded, okay? Because I don't want to destroy my eyes, But he did, and he now wears not only his prescription glasses, but he wears sunglasses on top of the true blue sunglasses on top of them too. And now he has no problem sleeping. Actually, he sleeps too much, I think. But,
I know the feeling.
You can't win for trying, right, Kerry?
No, you can't. Not when it comes to kids. So before we cut out a little bit when you said the true blue lenses. Are there any other brands, or that was the only one that you tested? That was the only one that I tested. And,
I have a foundation because they're a small company. Mm-hmm. And I didn't know if they're going to survive. So my foundation actually invested in them to make sure that they will survive, because we need that level of protection. Hopefully, if we show this to the industry, that they will rise to produce lenses and sunglasses that actually truly protect, rather than just appear like they protect you. Okay, so.
What's really sad is I recently went to a lecture, and I actually asked the speaker about blue light and is it dangerous to the retina, and he says, that's all bull. Now I'm talking to the world expert right here, so I'm glad to hear that it is not bull.
But it's the same thing that happened with cigarettes. It also is the same thing that happened with Coca-Cola. I shouldn't say Coca-Cola, but high fructose corn syrup. All right. There were pundits that said that, because they're aligned to the industry. You understand what I mean?
Right.
I mean, the biggest companies in the United States, they all want people to use the computer more than not use it less, right? I mean, Amazon, Apple, I can name. They're the most valuable companies in the world. Look at history. The most valuable companies back then were the cigarette companies. How long did it take how many people had to die from smoking cigarettes before we realized that, even now, people still smoke. Holy crap, right? People are still dying of lung cancer. What can I say? And then high fructose corn syrup. That's why we have so much diabetes.
Right.
We were told that this sugar stuff was good for you. We have an investor. His name is Warren Buffett, and he says that he drinks 6 cans of Coke or cherry Coke a day. That's why he's so smart.
Right.
Give me a break. I studied when I was a kid in mainland China, and there was the prime minister there was a guy named Deng Xiaoping. All right, and they would have commercials in communist China where they would show Deng Xiaoping smoking a cigarette, saying, "I'm 90 years old because I smoke cigarettes, Fortune brand cigarettes." Right? So you understand that there are a lot of scientists who will, how do you put it, be mainstream. Maybe they might be a consultant for Apple, or a consultant for Amazon, or do something with that, So they're going to say things that are not.
Follow the money, right?
Oh, well, yeah, follow the money. That's how it is. Yeah, exactly.
So when you're outside for like the morning sun, and it's balanced with infrared, and the UV, I guess, hasn't come, takes a little while for it to come up. It's safer, the blue light or sunset? Is it safer, or is it still just as bad?
No, it's just as bad. I'm doing a lot of research on using filtering blue light at the full spectrum for patients who have traumatic brain injury and migraine headaches. Okay, and we're actually testing this concept with one of the world's experts on concussions up in Canada. And what I found is that if you look at the tracks, okay, so infrared light and red light is actually very good. It's a healing wavelength of light, okay? And the issue is that the receptors for that healing wavelength of light are actually not found in the macula. They're found throughout the whole retina, all right? Same thing with the blue light receptors, but the blue light receptors, you know, that's the cone cells, right? You know, that's the cone cells. And so they are getting a lot of exposure to blue light, and the red cannot counterbalance that. It just doesn't happen. And this is the same signaling process that occurs in patients with migraines and also with concussions, because the brain is short-circuited, and red light and blocking blue light is going to be very beneficial for allowing the resting of the brain and to stop the stimulation of the brain. And this is a hypothesis that I've had for a long, long time, and now it's being borne out by having people with post-concussion syndrome and migraines wear this particular lens. When they've worn other lenses, it didn't block the full spectrum of blue light. It didn't help. And so there's a lot of scientists that go, oh, this blue lighting technology doesn't work. They're wrong. No, it does work. It's just that the technology that you were testing was ineffective because it wasn't blocking the appropriate wavelengths of light. That's all.
So do you need to block 100%, 50%, 70%?
Everybody has a threshold. It's a threshold, all right? If you block, the sunglasses that True Blue makes, 96%. That's pretty good, okay? And then these indoor ones are 76%. But compared to the leading like blue protecting lens, that's usually 12%, 13%.
Wow.
Now, it blocks. I mean, they're not wrong. They're not lying. It does block, but 13%. So think about, there was a recent article that just came out about skin cancer melanoma and the UV exposure, right? They found out that in non-Latino Caucasians, that 94% of melanomas are caused by UV exposure, right? That's brand new. That's not something that a lot of us knew. We thought it was, but it was actually proven. Now look how long it's taken us to prove that. So the suggestion now is that you have to wear an SPF of close to 30 to 50, okay? Anything low, but you go to the drugstore, all right? There's SPF of 3, SPF of 10, SPF of 15. Right. Pretty much useless, okay, you know? I would say that this indoor one is SPF of maybe 50, and then the sunglasses SPF of 100, if you want to compare and contrast, okay?
So let's talk about preventing macular degeneration. What are some of your recommendations?
Well, there's several. One is to avoid computer screens too long. Okay, I'm already breaking that because, you know, I'm talking with you, but I don't have my glasses because they're going to cause a filter. The next one is there are several supplements that I have studied. I actually have studied pretty much most of the supplements. There's a big supplement called AREDS, AREDS. That is not a supplement that I recommend anymore. I was one of the main investigators for that study, and there are problems with it. Not that it doesn't work. It does work, but it only prevents something called wet macular degeneration. But it may work by drying out the macula. And I told you there's another form of untreatable macular degeneration called dry macular degeneration. So there is some evidence that says that if you take this substance for the wet macular, to prevent wet macular, you dry out the retina, and as a result, your dry macular degeneration will accelerate. That's why I suggest no for that. Mainly because I already have a treatment for wet macular. It's an injection, okay? And actually, the minority of patients develop the wet. Only 10% of those who have macular degeneration develop the wet. So why will I give them something that's going to, how do I say, prevent the wet, but worsen the dry, which is the majority? So I don't do that, okay? Just out of common sense. Plus, there are toxicities with that formulation that are not so good, okay? One of the toxicities that's been known is that there was a component called, that caused lung cancer, all right, that we showed. There's also another component that is implicated in causing prostate cancer at the doses. There is a substance called zinc inside that formulation that is actually the active ingredient. The problem with zinc is that there is FDA warnings that say that you shouldn't take more than 40 milligrams of zinc for more than 10 days, otherwise you'll get neuronal damage. These formulations have 80 milligrams to 60 milligrams. And if you try to use less, well, it won't work as well. So why take it in the first place, right? So what do I suggest? Well, the protectant inside our eye. It's called macular pigment, okay? You understand, pigment is what protects our skin, our eyes, all our bodies from radiation, okay? And this macular pigment, oh yeah.
We lost you again, so if you could just pick up, what do I suggest?
Oh, what do I suggest?
Yeah.
Okay, what I suggest is a supplement which restores macular pigment in the eye. Okay, that is called mesozeaxanthin, lutein, and zeaxanthin. The brand name, I'm going to say it, is called Macuhealth. And Macuhealth is the only one that has the right ratio and also the right amounts of this to restore the macular pigment in the eye. Now, if you take that supplement, you have to take it with a sip of milk, empty stomach, and sometimes 1 to 4 times a day. I've been doing research on this substance now since 2008, and I actually have used it to stop or prevent the need for injections. And if you're getting injections, stop the need for continued injections. I have close to 1,000 patients where I have them on Macuhealth, and all I do is I follow them, I don't give them a shot, okay? Now, they are in varying doses, anywhere from 1 to 4 times a day. It's got to be taken separately. But I have a lot of happy patients who are not getting shots that I see day in, day out, and they're doing quite well on this supplement.
And how do you determine if it's 1, 2, 3, or 4 times a day, and at what time level? Is it breakfast, lunch, dinner, before they go to bed? How do you decide that?
Yeah, so breakfast, morning, morning, noon, night before you go to bed is for the 4 times a day. Now, my father developed wet macular degeneration, and I diagnosed him on a Sunday, all right? Because he goes, my dad is professor of ophthalmology at Harvard Medical School. And he goes, oh, I'm not seeing so well from my right eye. I think the cataracts are getting worse. And I said, Dad, I just looked at you like 2 months ago. Your cataracts weren't even bad, all right? I mean, the power of denial, even in a world-class, famous, ophthalmologist, retina specialist, still denies everything, you know what I mean? Like a cardiologist going, oh, the chest pains aren't bad, I'm not having a heart attack. I mean, seriously, right?
Right.
Well, my dad always says that he can dish it out, but he can't take it, all right? So when I diagnosed him with wet macular, he says, I don't want to get a shot. What are you talking about? You know what he said? He goes, who's going to give it to me? I said, well, you're sort of looking at him. No, you can't. You're my son. You can't give it. I said, and why not? So what he did was he did an experiment. He had been reading all that research I was doing, and he decided. He looked at one paper. And he's a scientist. He's developed surgeries and treatments. He's a professor at Harvard Medical School. Hello. So he looked at the papers and he saw one paper, which was the toxicity of this Macuhealth, or mesozeaxanthin, lutein, and zeaxanthin. He read and he pointed out to me that the toxic dose of this Macuhealth is 5,000 pills a day. And the reason why, in drug development, I'm a drug developer. I have founded 8 biotech companies right now. So I'm developing drugs for cancer, for Alzheimer's, for all these different things, right? At this very moment. So the main key to developing a drug is toxicity. If it's too toxic, who cares if it works? The toxicity of Macuhealth, 5,000 pills a day, was that it cured a model of liver cancer.
Wow.
Yeah, so we use the model of liver cancer to see if it's to hyperdose an animal, right, or a human, because it won't get broken down if you have liver cancer, and then you'll show all these different toxicities. But instead of making the dose so high and causing other toxicities, what it did was it cured the liver cancer. So the model was, it was useless, right? In terms of, so looking at that, my dad said, well, why can't I take 4? So I said, I don't know, well, go ahead, but I said he was crazy. Look, you have wet macular degeneration. I can see it. I showed him the OCT, he got the angiogram. Yeah, wet macular degeneration. I mean, I've never used this to treat wet macular degeneration, okay, only to prevent it. So he did it, and I made him a deal. I said, okay, you do what you want. Give you 3 weeks. 3 weeks, that's it, right? 3 weeks. So he did what he wanted. And I said, if it didn't work, I'm giving you a shot that day. And I'm not going to tell you anything. I mean, you're just going to get the shot, all right? So he took this 4 times a day. And in 3 weeks, his vision went from 2100 to 2050. He still had fluid. The bump went down to maybe 50%. So it was commensurate. So I go, what the heck? What'd you do? I thought he went to his student. Some of his students are the who's who in ophthalmology, like the chair of UC Irvine. I mean, you go around the world, and they're the who's who in ophthalmology. So I thought he snuck out, because he didn't want to get it from me. So I said, Dad, what the heck? What are you doing here? What's wrong with you, right? Why did you have to go to somebody else? And he goes, no, I didn't go to anybody else. I just took this pill. I said, you serious? The pill that I've been studying for almost 8 years, and you took it, and it actually works to stop you from having injections. So I followed him once every 2 weeks or so, and then in 3 months, completely gone, and his vision is 20/25.
Wow, that's a great story.
This was 2016. 2016. Today it's 2020, right? Not a single injection. He's still on the MacuHealth, and I check him now every 3-4 months, and he's perfect. His vision is better because the side effect of MacuHealth is that it improves vision. It improves visual function. That's been studied up the kazoo, et cetera. So a lot of athletes want to use it. I mean, that's their prerogative because like my son is a tennis player. He pops MacuHealth left and right so he can win tournaments. He actually made it to states in doubles in Florida. That's hard. And he's a short guy, so he doesn't have the advantage of being like a tall, a lanky Djokovic or something like that, right? So vision is very important, especially with athletics.
I give it to my son for baseball. His pigment is 0.86.
Yeah, I mean, it works very well in baseball. There are several teams who are probably using it as we speak, Major League Baseball. Yeah,
So are there any other techniques, food-wise, exercise, as far as preventing macular degeneration that you recommend?
What's interesting is that the discovery of this pigment MacuHealth, all right, is a culmination of nutritional studies. It started out with the carotenoid levels that were found in the EDIC study that was done in the 90s, which demonstrated that if you ate a lot of green leafy vegetables, that's kale, collard greens, spinach, if you're in the top quintile, you would have a benefit. Now, the issue is that there's been a big problem with our food, all right? That study was done in the 90s. And the spinach and collard greens and kale that were in the 90s were packed with the nutrient that's found in this MacuHealth. Now, because of GMO and also genetic manipulation, the amount of the substance in our spinach has now decreased to 121. So that means that a serving of spinach back in the 80s and 70s and so on and so forth has 21 times more of this nutrient that's found in MacuHealth than the spinach and the collard greens and the kale that we have now. So if you want to not take a pill, and I'm okay with that, I have some vegan patients, they tend to be Hindu from India, but they don't want to take a pill, correct? So I have them eat probably equivalent of 3 to 4 bushels of spinach a day. And they can do that. Cooked spinach, it comes down nicely. And if you're a vegetarian, that can be easily accomplished.
You said before that you study red light, and there's companies online that are selling red light bulbs. One of them is called Juve, where they recommend people to actually sit in front of these red lights, and that it's good for their health. Do you know anything
Yes.
about that?
Sure, absolutely. The infrared wavelength actually, well, there are several effects. One is in the cellular level, all right, and the other is in the neuronal level. In the neuronal level, red light behaves as a form of sort of, it like down regulates the activity in your brain. You know, our lives are very stressful, correct? And so our brains are always moving very, very fast, maybe too fast for their own good. And as a result, that can accelerate certain things like, you know, Alzheimer's or dementia, all that kind of stuff, right? Well, the red light actually turns on a pathway in our visual system that affects a certain part of our brain, especially in the pineal pituitary axis, that can actually, it sort of allows the brain to sort of relax and heal up, all right? That's why maybe in sleeping, you know, you do that same thing. At the cellular level, infrared light is synonymous with heat, right? And as you know, in everything, like our muscles, our skin, etc., heat or infrared is actually going to be a very, it's a healing wavelength of light. Now, I can go through the molecular basis of this, but this would be a bit far-fetched for our audience today, but I have studied this extensively. I've conceptualized potential technology that could transform, using pigments on the lens, transform high energy visible light and bring it a step down to emit an infrared wavelength. So you could have therapeutic glasses for people who have either brain injury or Alzheimer's or other neurological issues. My sister has end-stage Parkinson's, and manipulating light on her, I mean, you never want to use your family members as, you know, as guinea pigs, right? But, you know, that's what I do. Like, look at my dad, you know, I mean, but he made himself a guinea pig. You know, I call him like Dr. Frankenstein, you know, he's doing his own, you know, own time of research on himself. A lot of scientists are like that, by the way. I am like that, you know, I'm on MacuHealth because I did a research and I experiment on myself to see if it does improve my vision and all that kind of stuff. And it does. Same thing with the infrared red wavelength of light situation. It's a very powerful tool. It's just we don't have the boundaries of that technology yet. You know, what wavelength is appropriate, you know, and also what intensity. All these things haven't been really worked out. They've been worked out in cell culture. They've been worked out in the basic science, but applying to clinical realm, I mean, I can't attest to that yet, because delivery is going to be very, very critical.
Whether it's near infrared or far infrared, that type of thing.
Exactly, yes, exactly. It's the wavelength. I mean, it's just like blue light, you know. Most sunglasses protect against 400 to 420, but the big problem is 420 to 470, right? That's the problem, and almost no sunglasses protect against that. Right. So same thing with infrared. Is it the far infrared, mid-infrared, or near infrared? Don't know, not yet. Working on it.
One last question to ask you before I let you go, and I really appreciate you. You've been so generous.
This is fun. This is great.
Talk about medications. I find it fascinating when medications affect the retina or different parts of the eye. Can you talk about some of the common medications that could affect the retina?
There are a lot of common medications that can affect the retina. I guess the most common one is aspirin. All right. If you're diabetic, or if you are, if you have a retinal detachment or retinal tear, or if you have a macular degeneration, taking aspirin once a day, if you don't really need it, could cause your eyes to bleed more and bleed so badly that you go blind. Of course, that goes along with all the other medicines as well, like Coumadin, Plavix, you know, Pradaxa, all these different blood thinners. All right. So that is probably one of the most common medicines that is overused and results in retinal or vision-threatening situations. Okay, that's number one. Then there are other medicines that are toxic, potentially toxic to the retina, that are used in other forms of medicine. For example, rheumatology. One of the mainstays of treatment for SLE, or lupus, systemic lupus erythematosus, is called Plaquenil. Now, Plaquenil has some problems because it's derived from a anti-malaria drug called quinine. Quinine in high doses or long-term use of quinine will lead to irreversible blindness. It'll cause a macular degeneration that is not far-fetched from dry macular degeneration. It's an accelerated form. So the problem is that we don't have to give quinine to patients, but for those who have lupus or other rheumatological disorders, Plaquenil is a mainstay of treatment. Now, it's a really good drug, except that it can cause blindness, which is kind of, not a great thing. The other ones, of course, are in the chemotherapy realm. There's a drug called tamoxifen that is given to a great deal to patients with certain solid tumors like breast cancer. And there are also some derivatives of tamoxifen that can cause a retinopathy. That's not as common, but having worked at both the Dana-Farber at Harvard and the Abramson Cancer Center at the University of Pennsylvania, I saw enough of this in the eye that's a problem. The other thing that I see a lot of actually is problems with veterans, veterans who were exposed to Agent Orange. So while I know that's not a drug, it is something that, I used to run the VA Retina service in Philadelphia for 5 years or so. And I saw a lot of eye disease that was unusual in patients who had been really bathed in Agent Orange in the Vietnam War. And I put that as a drug. Okay, I mean, I know, I see this a lot. I actually saw 4 patients with Agent Orange exposure that I'm treating, and they're really weird. It's like, this is weird retinal stuff, and it has to be that exposure, because I don't see this kind of manifestation. It sort of looks like macular degeneration, sort of looks like diabetic retinopathy, sort of looks like all these other diseases, but it's not. And that's why I call it exposure to Agent Orange. But that's not going to be defined. And that's fine, I know that the VA or the government doesn't want to study that anymore, and so it's just the way it is. But those are the common medication-related problems. Of course, I also see patients who are on antipsychotics or lithium, for example, or Meloril. That's not as frequent. But my wife is a psychiatrist, so she always points out these cases to me. It's not something that I see often. So,
how about statins? There's a lot of controversy around statins.
Well, in the eyes, there's my mentor. She's the chair at Harvard Medical School. She's been studying the use of statins in macular degeneration, and she has really shown some strong effects of statins. But there have been other people saying that statins may have some toxicity to the back of the eye. I'm not as versed at that. Again, politically, there's a lot of benefit. There's always both sides to the equation, right? And I think that the evidence that statins are helpful to the eye in certain situations is stronger than the toxicity side. Okay. Yeah.
And do you ever think that we'll see an anti-VEGF eye drop instead of having to do the injection for macular degeneration and diabetes?
I'm currently working on that. The problem is that the people who make the injections, right? It's sort of like a monopoly, right? So as a result, there's a lot of resistance to developing an eye drop, and that's all I can say about that, unfortunately.
Well,
so.
I want to thank Dr. Tolentino. He is a wealth of information. He's one of the top retinal people in the whole world, not just in the U.S., but worldwide. Dr. Tolentino, if somebody wants to get in touch with you, or they want to see you as a patient, how could they do that?
Oh, easy. Just call my office. I actually have offices now in, I'll tell you, a lot. The Villages in Florida, okay, Clearwater, all right, Lakeland, Lake Worth, Delray, Boca Raton.
That's fantastic.
I span, so you'll if you come to Florida, I'm just an hour or less from wherever you're going to be, right?
Well, I really appreciate Dr. Tolentino spending time with us. He's a true genius. He saves people's eyes. And thanks so much, Mike.
Can I add one more plug? Okay.
Sure.
I'm doing a lot of research, clinical research. I'm actually in several trials, all right? I have trials for the dry macular degeneration. I'm in trials for wet macular degeneration. I actually am developing a pill for wet macular degeneration, all right? I'm also doing diabetic retinopathy trials. There is one condition that happens in diabetic retinopathy where the blood vessels block off all the flow to the center of the vision. It's called macular ischemia. And I'm doing the first study ever on trying to take care of this disease. And I'm the lead in the world, okay? So I'm just saying.
If somebody wants to be in that study, how can they want to have one of these?
Call the office. Look me up on the internet. Okay, I'm pretty much all over there. I just got top doctor in 2 locations in Florida. You know, and so I'm out there, right? So just look up my name, and you'll see where you can call my offices, and then depending on where you're located or where you can go, I can try to screen you for one of the studies. I'm going to be in close to 20-some studies by the summer. So
we'll put Dr. Tolentino's information in the show notes. So
yes, please.
if people want to get in touch with Dr. Tolentino, we'll make it a little bit easier.
Yes. I'm giving patients tomorrow's medicine today.
Thank you so much, Mike. I really appreciate it.
All right. Thanks a lot.
Since I bought Safe For You, my dad makes me clean his boat.
Es natural y es un buen producto.
Every time I go back to school, my mom always makes sure that I have my Safe For You products. I like to bring extra, and my roommates certainly don't mind.
It's a good thing I had Safe For You to clean up after this little guy.
When my hands get dry, I like to wash them with Safe For You.
And most importantly, the reason why I buy Safe For You is because it's safe for me and you.